Thank you very much. Thank you to the organizers. Thank you, Mark, for this invitation to talk to you on new formulations, deliveries, devices, and how they're helping us. Here are my disclosures. I have two stories to tell you. The first story is to tell you about what happened today. So I arrived yesterday with that gentleman from Qatar. We were on the plane. Very nice hotel. Everything was going all hunky-dory. This morning I went to the gym. You know, I'm getting old, so I need the gym. Went to the gym, came back, got ready. And then when I was about to come here, I looked for my suit and I couldn't find it. I forgot my suit on the plane. So I panicked, and then I thought about it. I thought, well, I've known Mark Nelson for about 22 years. He always wears that flowery shirt. I've got a flowery shirt. I thought it'll be fine. It'll be absolutely fine. I can get away with wearing a shirt like that. And then I thought about it. Dr. Hussam works with me. If he sees me in that flowery shirt, he'll fire me. So I decided to run across to the plaza, bought a suit, came back handsome, presentable for the Gulf. Okay, that's the first. The second is this story about this 19-year-old female who I had the pleasure of treating in Liverpool. So 19-year-old female, she has a background of attention deficit disorder, for which she's on treatment, which she's had since she was 4. She has because of her disorder, she has quite antisocial behavior, smokes cannabis on a daily basis. Alcohol is a big feature, and she's been treated for various STIs and multiple partners. So going to the bottom right there, you can see that, not surprisingly, she was diagnosed with HIV back in 2015, wild-type virus, a good CD4 count, but a moderate viral load, Hep B and Hep C negative. She was keen to start therapy, and we did quite a lot of work with her social worker, psychiatrist, just to get her ready for treatment because of her background of ADHD. And then moving to here, you'll see that she started various therapies, and all of them lasted for maybe 2 days, maybe 1 week, and she just wouldn't take it. So she was on Triamex, she went on to Simtuza, she went on to Biktarvy. Those are the actual drug names there. And we never really had any success. Now, she maintained having a good CD4 count. So we weren't really worried about her, although there was long-term health, but it was more the onward transmission. We knew she had multiple partners. We knew we had a lot of work. We gave her condoms, but she admitted multiple partners, and that was ongoing. So with the 2 companies that make the drug, at the time it was compassionate use in 2019, we had rilpivirine and Carbotegravir injectable, which we started immediately in her rather than with an oral lead-in. And within a month we had her undetectable, and she remains to this date undetectable. I checked yesterday. CD4 count is over 900, viral load undetectable. She continues to have her problems and her demons, but she's supported a lot. So a success story with a point to make there. So the cases for today, and the aim of today is really to talk to you about the types of long-acting preparations and where they can be useful, the conveniency of dosing that they provide, which drugs are in the pipeline in terms of long-acting, what are the side effects potentially for the ones that have been studied, what about the lead-in of oral, how do we get around that, or is it essential? What about the long tail? The drugs can hang around a long time. You don't want functional monotherapy. And what about drug-drug interactions? Now, I'm going to just give highlights because I have 25 minutes. I can't go into depth, but we can always discuss over lunch if you want details. So long-acting technologies and the drug delivery options that are available. I'll start here. There's the oral, which can be nanoformulations, so slow-release, long-acting nanoparticles. You have injectables, so I will talk about the 2 injectables, so Carbotegravir, rilpivirine. Microneedles, I'll talk to you about that and show you some early data from CROI. Subdermal implants, very similar to Implanon, the contraceptives. Vaginal ring, doravirine, vaginal rings available, can be used as PrEP even. Wearable infusion pumps, like we already see that with insulins, yeah? So you're familiar with some of these in other therapeutic areas. So what is the conveniency that they bring about? The dosing is reduced and reduced pill burden. So some of them, the oral ones, the long-acting, the dosing can be given once a week. For the injectables, once a month, some of them even twice or once every 2 months. So once every 2 months. And an implant potentially once every 6 months. So it's a conveniency in terms of dosing. But it's not just that. It's reduced number of pills. You can see, and the first speaker showed where we were in the past to where we are at the moment, but we can even improve on that to reduce the number of pills, reducing the number of drugs. So we're talking about 2 drug combinations, reducing the dosage, the number of days on ART, and increasing the dosing interval. And of course, this gives choice to our patients, convenience, and more importantly, it improves adherence. And also there, especially in our setting, but actually this is a global problem, that fear of disclosure, and I'm sure we'll talk about stigma later on. So there is something on the table for everyone, potentially. These are the molecules, sorry, it's a bit small, so you might not see it from where you are, but these are the molecules that are, at the moment, either in various phases, 1, 2, 3, of development. So you've got your Carbotegravir, Rilpivirine, and Carbotegravir. I'll talk about the top 3, Dolutegravir, Islatravir. I'll also talk about that. And then there are various forms of tenofovir, either the prodrug or the actual drug, which are in development in the long-acting. I'm sure there are other drugs, but these are the ones that I could talk to you about. So microneedles. This is where you essentially mill the drug, you break it right down, you mill it down into nanoparticles, and then you load the nanoparticles at high concentration into an aqueous gel, the size that's like, on your thumb like that. And then that can essentially be packed and can be placed as a dermal implant, which can be, be pricked in there. I've got another slide to show you that. So that's how it would penetrate. Each one of those would contain the drug, and that's the size of it, and you can just patch it onto there. Again, that's quite easy. If we look at other therapeutic areas and know that HRT is available as a patch, we know that, so it's not something that we're unfamiliar with, but maybe the arrays of the microfilaments would be something that we have to look at and get used to that. So there are trials that have been presented. This was presented at CROI. This was with TAF, and this was presented by Gilead, and then ViiV presented this with Carbotegravir. This is using the microfilaments as a form of delivery, and obviously that provides the convenience, but it also means that if there's a problem, unlike an injectable, you can take it off. So immediately you can take it off, and there is a choice there. So moving on, so now I'm going to talk about injectables. So mainly I'll talk about Carbotegravir long-acting with Rilpivirine, because that's available now in clinical practice, as Dr. Wali said, that this is something that we thought would be in the future, but now the future is here. It has FDA license, it has a European marketing, and I'm sure Mark will tell us his experience of Carbotegravir long-acting and Rilpivirine. I would say it is available. There was a lot of hype that it's for everyone. I personally don't think it's for everyone, and we can talk about that during Q&A, but it's a wonderful option. So Carbotegravir, like Dolutegravir, is an integrase inhibitor, a structural analog. You can see that there's a lot of similarity. They're cousins. It's available as an oral tablet and injectable as long-acting. It has a long half-life, so it's ideal for that. So here, when we're looking at Carbotegravir and Rilpivirine, slightly different mechanisms of actions. One integrase inhibitors, one's an NRTI, as you know. Very good in terms of DDI, the lack of DDIs, which we'll come to at the end. And as I said, oral formulations are available, but they have a long half-life, so they can be dosed either monthly or once every 2 months. So if you want to go and look into depth in terms of the data that is available for the phase 3 for CAB and Rilpivirine long-acting, you will see these registration trials. So we've got the FLAIR, the ATLAS, and then the ATLAS 2M. So FLAIR and ATLAS are looking at monthly dosing versus daily oral. And then that rolls over, and I'll show you the study design next, into ATLAS 2M, which is where the dosing of twice monthly versus every 2 months. So monthly versus every 2 months. So again, you might not see it from the back, but this is the study, the design for Atlas and Flare, which is comparing initially, these are all naive patients. Initially, you will see that the patients had essentially Triumeq, dolutegravir, bacavir 3-TC, or they went on to oral CAB, and then here you have, and they're randomized 1-to-1, and then you have oral CAB versus injectable long-acting coming in there, okay? And then at week 52, you've got the extension phase. In summary, and I know I should have gone and showed you the baseline and all that, but that's something that we can look at. But essentially what you're seeing in Atlas and in Flare is that Carbotegravir and rilpivirine long-acting achieved high rates of virological suppression. And over on that side, you can see in the forest plot non-inferiority versus the oral standard of care, which you saw in the arms there. So non-inferiority has been demonstrated with the long-acting Carbotegravir and rilpivirine. In the Atlas 2M, remember they're now looking at the dosing variation between 1 month and 2 months. And that's essentially what the primary endpoint was week 48, but this goes on, and I'll show you both short-term and long-term data. So this is at week 96, again showing maintenance of that virological success, whether you're doing it Q4 or Q8 weekly, 2 months or monthly injections, and you can see non-inferiority with the confidence intervals very tight within that 4% margin. So non-inferiority demonstrated. So this is now showing you long-term, or as long-term as it can be, up to week 256 for latte, which I didn't show you the study design, but very similar to Atlas and Flare, week 152 and week 124. So we're getting data now of long-term maintenance of that virological success. Looking at what are the adverse events. So one of them is injection site reactions. I think we all know, we're all familiar with ISRs because we've all been getting our COVID vaccines and getting our ISRs. So again, the main thing here is that they get better over time. Okay, so initially, that's the main thing that's complained about, but with each dose and each dose, it's less and less, which is good news. Other things that can happen, it's what was reported in week 48, headaches, some pyrexias, but these were very minimal. The majority were these ISRs, although they were less than 2%. And over the time, they declined, as I said, with a median duration of about 3 days. Well tolerated is the conclusion there. So what else do we need to know about these long-acting? So it's the pharmacology. We need to know about how long. What about if I miss a dose? What does that mean? What about that lead-in? My patient, the example that I gave, didn't have a lead-in. What happens there? What about drug levels in renal patients, in hepatic impairment? What about TB? Because in our region, globally, TB is a co-infection is a big problem. Can I use rifampicin or rifampin drugs? What about DDIs? So here, again, looking at Flare, looking at the oral lead-in versus direct to injection, what you will see is at week 1 post-dose, 4 weeks, looking at the drug levels, it didn't make a difference. So you can, like we did in our example, go directly to injection. Obviously, the reason one wants an oral lead-in as well, if the patient has never had these drugs, is hypersensitivity reaction. Because obviously, we know these are unpredictable. You cannot predict who will have an HSR. This is not the same as an HLA B5701 reaction, and these drugs have no propensity to that. But it's that, that unpredictability, and hence the oral lead-in to say, look, I can start and stop at any point. If there is a problem, the microarray, I can take it off. And so therefore, it makes sense. It makes sense to have an oral lead-in. But in our case, in our patient who could not take a tablet at all. If you can imagine, Biktarvy was too big for that patient. Simtuza is big, but Biktarvy was too big for that patient. We went directly to treatment, and these are good data, which are comforting to see that actually one could do this as a strategy. And then around how do I have to dose exactly at 1 month or 2 months, exactly. There is a window. There is a window of about 7 days. Okay, there's 7 days. And this is thinking about patients who want to travel, patients who can't make it to clinic on that day. Maybe maybe that day runs on the weekend. Maybe it's on the Friday and they can't come to clinic. And so it's around that forgiveness that there is at least a 7-day forgiveness period. Looking at the plasma, looking at the the PKs are actually very good for these drugs. So if you're looking at CAB here, and then over there you're seeing rilpivirine, you see steady state by at least week 48 being maintained well above the protein adjusted IC90, so the inhibitory concentration, the minimum effective concentration. So you can see that we're well above. Clearly with rilpivirine, some of the confidence intervals are going right down and coming close to, the bars, are coming close to the IC90, so we worry about missed doses there. Coming to the long tail and missing doses, so we know that these drugs are long-acting, and this is pretty amazing. I'm going to walk close so you can see. That's 12 months. I inject you, and that drug can stay in your system for up to 12 months. Clearly, it drops way below your minimum effective concentration, but that's therefore that potential area of functional monotherapy of resistance. And therefore, a bit of thought has gone into this. So, and this is another way of showing you the same. So the lighter color is the CAB and then the rilpivirine. You can see there at 1 month, 3 months, 6 months, 9, 12. And you can see increasing levels of drug loss, essentially, vulnerability to resistance. And so it's how do we manage misinjections? What do we do? And so you can use the oral formulation as a bridge. So a patient who has a planned, I'm not going to be able to make it to clinic in that window because I'm traveling, or I want a break from my injection, whatever reason, you can use the oral formulation as a bridge-in. For those patients who you're switching therapy for whatever reason, it doesn't matter because you're switching and therefore maintaining them suppressed. So if the drug levels are hanging around for 12 months but are going down and down and down, you still have HIV controlled with whatever combination therapy you've moved to. So it's not all doom and gloom. There is logic to it, and it is manageable. And the oral formulations allow us to bridge through these missing dose. Obviously, in the trials, they also looked at long-term adherence because we do worry about that missing dose. They looked at in FLAIR and LATTE, and they actually showed, okay, this is in a clinical trial setting, but in FLAIR, at least 43% were within that day, on that day, but most patients were within, standard deviation. You've got a nice little normal curve of reporting and having their injections on time in a trial setting. Coming towards the end, for CAB and rilpivirine, CAB and rilpivirine do not require dose adjustment for mild to moderate hepatic or renal failure. So GFRs down to 30 are fine. Less than 30 is not been studied. And the same thing with hepatic child's Pew A and B. Just to talk about DDIs. So in terms of DDIs, Carbotegravir, like most of the integrases, is UGT1A1 metabolized, so glucuronidation rather than 3A4. Rilpivirine is largely 3A4, but low propensity. Many of them do not cause, these two drugs do not cause DDIs. They do not lower levels of other drugs. However, they could be victims themselves. So this is a summary slide. I've had to cut out some of the details. So you want to avoid potential enzyme inducers in the liver, okay, because those will still be effective. You are losing the effect of oral drug-drug interactions, so cations, divalent cations, which bind to dolutegravir, which binds to Biktarvy, So you lose that in a good way by using injectable because you bypass the gut. But the CYP, cytochrome P450 enzyme induces potential ones, rifampicin, carbamazepine, etc., should not be co-administered, both for CAB and for rilpivirine, as well as some caution with some of the antibiotics like clary and erythro and methadone. And just looking at that question of TB and rifampicin, you can see here, this is the oral, that's the long-acting, and this is looking at area under the curves, the drug exposure, and you're seeing with the oral that you get a significant reduction, 59% for CAB, 80% for rilpivirine, contraindicated with TB drugs with rifampicin. You can see it there with the long-acting, you still see an area under the curve reduction of 80%, contraindicated. If we look at with rifabutin, there is a reduction of 21% with the oral, 46% with rilpivirine, therefore it's contraindicated because of that 46%. I think we'll see some simulated data in terms of rifabutin with Carbotegravir and rilpivirine coming out in the future, but we don't have that data at the moment. So moving on to other drugs, which are long-acting, injectable. This is subcut. Lenacapavir is from a different company. This is a capsid inhibitor. It targets multiple stages of the HIV replication cycle, and it is very early. We're seeing exciting data coming out of CROI. There is an oral formulation. There is a subcut formulation. And this was Capella was the monotherapy arm to just see, is it effective in patients with heavily experienced patients who have been exposed and have got multiple class failures. So the monotherapy answers that bit. So you're seeing an almost 2-log drop in viral load in the arm with Lena, which is reassuring, shows you that it works. And then in combination therapy, when you're looking at that, you're getting good suppression in heavily experienced patients. So these are patients who are getting subcut injections. And then you can see Calibrate, which is further extension to looking at lenacapavir combined with Descovy, essentially with FTAF, and then looking at the efficacy of that. And then here, rather than the snapshot in the T-Lover version, you can see very good virological control with that very early integrase type of effect with very early control in viral load. So when we see what else is in development, so from different company, from Merck, we have islatravir. The drug names are not easy. In development, both orally, and then we have it in combined once weekly with lenacapavir from Gilead, long-acting injectable, which will be given 3 monthly, and then potentially looking at once yearly implant. So, really exciting. Get used to this laser art. So laser is long-acting, slow, effective antiretrovirals. And here, this is very early data, which was shown at CROI. So monkey tissue data is looking at dolutegravir and as the prodrugs. These are drugs that can hang around for a year. You're thinking about dosing a patient once a year, potentially, and looking at the levels in PBMCs showing that they stay up really for a really long time. And we'll be looking forward to seeing this data being translated into phase 1, phase 2 human studies and seeing how that goes on. And then just to end on this, the GLAD, which is a really ambitious program, global long-acting drug combination to look at the generic, the generic TLD, tenofovir, lamivudine, dolutegravir, to say, can we take that pill, that single pill, and make it long-acting and make it available to low and middle-income countries, which is, ambitious and great, and to have regulatory and commercialization by 2027. I think this is great. This is work that has begun, looking at the idea of maybe self-administration of injections or at least assisted dosing. And this is TLD, as I said, that is already available as a single tablet, which is about actually $60 per year as a tablet. And then here you have it there potentially as a long-acting. So long-acting drugs, we know from other therapeutic areas, we're already familiar with Norplant and Implanon, etc. So this is my last slide, just to say we have seen the evolution of HIV from AZT in 1987 to triple therapy heart in 1996 to STRs in 2006 to the integrase era, and now we're actually in the area of injectables, which is really, really amazing. I would like to acknowledge people who have helped me in my career and who have also shared slides with me, and to Mark here. Thank you very much.